To this session on natural disaster and mostly on amputation. The idea of this session was coming from the last symposium we have on the topics in Göteborg, with the presentation of some kind of debriefing after the earthquake in Haiti. You know that CICOT is working with MSF Belgium, that we have 80 CICOT members who are volunteering to participate to surgical mission, orthopedic mission with MSF. And it comes out from the experience of those who went to Haiti, from the symposium we had in Göteborg, and for another meeting in the SOFCOT, the Orthopedic Society in France, in Paris, in November after. That's one of the most difficult problems for the orthopedic surgeon, the young one, but also sometimes the older one, is to make a decision regarding the amputation. And in addition, it was a lot of controversy regarding the type of amputation. It was a lot of discussion about the guillotine versus more closed amputation. And so I think the subject really deserves to be discussed further. I introduce also my co-chairman, which is Joël Boss from Médecins Sans Frontières France. And we will now start the session with a lot of people who really have direct participation in the different aspects of the humanitarian mission at the time of the natural disaster. So the first orator will be Patrick HERARD, please.
Right button? Okay. Well, thank you very much. Of course, I will take Haiti's example to speak of amputations, as you said before. There. You? Okay. Just short reminder that what is MSF for a few of you who don't know exactly what's it. We are organizing and intervening in armed conflict, epidemic, natural disaster, and healthcare exclusions. This is just an example of how we, of course, try to save lives, but relieve suffering and restore dignity and independence. And I think that amputation are a good example of that. So, what do we know from our experience? In these natural disasters, 3/4 of injuries are on limbs. If amputation itself is always a difficult decision for a surgeon, it's worsened by the context. And for me, the context has 3 factors: a human factor, a facility or setting factor, and a cultural and sometimes religious factor. In precarious conditions, we can say that nearly half of open fracture will always end either by chronic osteomyelitis, osteitis, or non-union. We have 2 publications there, one from International Orthopedics, the other from Journal of Trauma, 43, 55, so roughly half of them. So what are these factors in this context? First of all, the human factor. The patient itself, well, we cannot change anything, and it's the same than in any other kind of accident or RTA or whatever, it will be the same. But the medical staff will be totally different. Unprepared surgeons are a menace in disasters. That's Jones who said that in 2003. Volunteers without any previous war or similar experience are a burden. They need to be adaptable in resource-deprived situations, grounded to protocols, and for MSF, our protocols, of course, and able to step away from their conventional practice. You can imagine that as many as 15 to 20% of limbs may need amputation in some disastrous situations. And this is really a great shock for a civilian surgeon who never went there. Facilities and settings. This is just the example of Haiti. Needs are enormous. We sent 17 planes to Haiti within the first 10 days, just to explain how difficult the logistical aspect is important. Of course, water and electricity and so on. with full kits. This is the hospital with 13 inflatable tents, radiology, rehab facilities, and all these things. This is just the example of the recovery room and of the OT room and the sterilization. So this is the sentence I picked up from Dr. Helfet in New York. On January 17, he contacted the chief CEO of Synthes, who said, well, I'll give you whatever you want. And he provided his company jet. When he landed to Haiti, there were about 1,000 patients in the main public hospital waiting for treatment without electricity or water. They left for a small community hospital. In a few days, 2 or 3 days, they were out of any supply. Patients started to become angry. They left on a Canadian charter plane. So his conclusion was, you just can't go there alone. It's inefficient and distract from your work. Then an aspect that I want to point out is a cultural or religious aspect. Everybody knows about the Sharia law, and there are some areas, and these are 2 sentences from the Quran. Human body belongs to Allah. Man has a formal commitment to preserve his body integrity. And in some countries, the application of these sentences is very strict. If you go to Somalia, for example, you just cannot amputate. So this is a very strong aspect, and you have to be very careful about that. So after this kind of earthquake or big events, what's the burden? This is a picture from Karolinska Institute in Sweden, which shows you what's the burden of your work, what will you have to do during after an earthquake like this. So, of course, your elective surgery is gone. Your trauma surgery will be extremely high during the first day. Then it will decrease, but the burden will still be there till months 2 or 3. So IT has this example. Just to be short on that, everybody knows these figures. So that's the context. And this is, again, you have to really understand, this was our hospital here. Before the earthquake, after the earthquake. The OT was at level 1. The OT just after the earthquake was on the ground, totally destroyed. So, okay, these are the figures of the all combined MSF during these first three months, and the total number of patients we treated there, more than 5,000. And if you look at the number of amputation, the total number of amputation for MSF, it's less than 4%. And as you can see, most of them during the first months, and in fact during the first 2 weeks. Amputation became very public and mediatized, and I will speak after of the article in Le Monde, following the preliminary report from Handicap, who said that the number of amputees will be more than 2,000 and eventually more than 4,000. In fact, the reality from the last PAHO report is nearly 1,200, roughly. It seems that's the good number now. But my concern is that the level of the amputation, most of them are upper knee amputation. This is the article of Le Monde, who says that a lot of surgeons, especially from US, were doing wrong surgery, and were doing guillotine amputation, and were doing a lot of, it will be very dangerous and very harmful for the patient after the earthquake, and after they are gone, of course. So just a few examples of what we have seen in Haiti. What do you do with these examples? Do you operate them? Do you try to be conservative? When you are in the street, like this, for 10 days? Is this acceptable? This is a case I've seen three months after the earthquake. What's the purpose of that? That's ridiculous. It's a waste of time, a waste of money. It's painful for the patient. It's ridiculous. And the patient refused amputation after 2 or 3 months because he's convinced by the surgeon that he will be saved. So I don't have the total figure of all the MSF, so I just I'll add all the operative report from MSF France. So for the first 12 days, we had these amputation, 29 amputation on 26 patients. You can see most of them are during the first week. I have a formal indication for most of them, except in 15% of the case. But you can see that roughly half of them are a first indication straight on when they come, and 38% as second operation at day 3 or 4. So when I'm briefing the surgeon for MSF going to the field, what I was saying before IET, I've changed now. I will explain you why. So I was saying in my setting, with my facility, and it will change according to an area to another one, to the cultural, the religious aspect eventually. Will this patient be able to work on it within 12 months? We never stay, generally speaking, on emergency situation more than 12 months. If the answer is no, you should consider amputation. If the answer is yes, try to conserve it. If you don't know, please try to conserve, but seek again, but never endanger your patient from infection. So, and always consider for amputation, severe nerve damage, especially the sciatic nerve, or if you, of course, you have an early gangrene. Again, a sentence from Jones. Limbs with vascular nerve injury in resource-poor settings are usually best amputated, and there is a little place for multiple procedures. So from IET, I've formally introduced the Mangle extremity score to all MSF reports. Any surgeon now in this kind of earthquake or catastrophe has to fill this form, has to fill an easy operative report, the Mangle extremity score. We choose this one on a working group in MSF because it's very easy to use. It's 4 questions. So you can easily say that your score is below 5, up 7, and you have an argument, and then we will be able to take back all the files and work on that. All other scores that they can find in the literature are more complicated, and I do think that on the field, this is something very accurate to be at least an information in the operative report. What are our golden rules? Upper limb had to be, of course, as long as possible. Lower limb, we always do below knee or upper knee amputation, never through knee amputation. This is forbidden. We use tourniquet. Guillotine amputation is strictly forbidden in MSF, and we always perform a delayed primary closure. And of course, don't forget about this. You need a good pain control after, and you are the physiotherapist. Then you will have other NGO who will come, HI or whatever. But originally, you are the physiotherapist. You have to do the first dressing to shape your amputation. Again, just to show that this is strictly forbidden. We only accept a fish eye stump, and again, with the consent, of course, of the patient. We never take a decision alone, with the anesthetist and with the patient or someone of his family, of course. Thank you very much.
Thank you. I maybe propose to have the discussion all together and the end of the